Bene, allora possiamo iniziare, possiamo partire con i lavori della giornata di oggi. Allora chiamo il professor Barry Bultz, Professor and Head, Division in Psychosocial Oncology, Daniel Family Leadership Chair in Psychological Oncology, Cumming School of Medicine and Tom Baker Cancer Center, University of Calgary, Canada, Past President della IPOS, della Società Internazionale di Psico-Oncologia. Lo traduco anche per voi, professore ordinario, naturalmente professore responsabile della divisione di psicologia sociale e psicosociale di oncologia a Calgary in Canada. Welcome Barry, take your lecture. Check. This one.
Hello.
That's good.
Buongiorno. That's the only Italian I know how to speak. So I'm glad I met with many students today, and I know that many of you, if not all of you, speak English, and so welcome. And I'm delighted to be here in Ferrara. It's my third occasion. I've been invited by Dr. Grassi several times to come and meet and present, so I'm delighted to be here, and thank you very much. The title of my talk is different than the title you have in your paper, because in the paper it's called The State of the Art. But really, psychosocial oncology is more than an art. It is about the science of caring. And I'm going to talk to you a little bit about that today. It's a very brief description of how we reached some of the scientific conclusions that we made, but I will at least give you a thumbnail description of what we were able to accomplish in the last 20 years, 25 years, in terms of our research and our education and our improvement in patient care. In my presentation, I have two videos that I'm just going to preface so that I don't interrupt the flow of the conversation today. The first video is a video by Ted Kennedy Jr. He is the nephew of the former President John Kennedy. He was invited to a meeting that we had in Canada, and he talked about his cancer experience. Ted Kennedy Jr. suffered from a sarcoma. He lost his leg, and he's going to share what it was like being a cancer patient when he was a young man. And then I'm going to, at the end of the presentation, if we have enough time, Dr. Grassi told me I have only 45 minutes exactly, so I will try to stick with that. But the last part of my presentation is a series of patients that I've worked with that will talk about their own experience. And so I want to conclude with that, summarizing what we're really all about here today, and that's to improve patient care from time of diagnosis, treatment, recurrent disease, and even palliative care. And I know that you're going to be talking about end-of-life care later on, so we'll put this in context for the day today. So if I could remember the instructions that I had, I'll give you a little bit of a brief overview of the experience in Canada. Canada is a population of 40 million people, so in context, there are 121 cancer men diagnosed with cancer, and 45,000 of those men will die from cancer. And women, there are 113 women diagnosed with cancer every year, and 40,000 of those women will die, roughly 25%. On average, 641 Canadians are diagnosed every day, and 233 cancer patients in Canada will die every day. So I guess the data around 25% is probably pretty consistent here in Italy as well. So nearly 1 in 2 Canadians, 45% of men and 43% of women were expected to develop cancer over our lifetime. Basically, one in two individuals will develop cancer over our lifetime, and 1 in 4 Canadians will die of cancer as a result of the diagnosis and extension of the disease. So the comments that I hear frequently from the patients that I treat, the first question is, am I going to die of this disease? Cancer is a terrifying illness. No matter the advances that have been made, it still creates a degree of high anxiety for patients, family members, friends, and community members at large. Other comments that I hear from patients, I'm afraid of the pain and the side effects, like I'll lose my hair, will I be able to eat, will I be able to do any of the things I used to do? I worry about how cancer will change my relationship with my partner. Who will take care of my family if something happens to me? What if I get well, but the cancer comes back? There's always the fear of cancer recurrence in many patients for many years following that initial treatment and cure. And cure is somewhat elusive because the fear of recurrence continues. And the last one is, I don't want to be a burden to my family and my friends. And I hear that a great deal, particularly with patients that are in advanced cancer state. So to refer back to Plato, he said in 428 BC, before the Christian era, the cure of many diseases is unknown because we are ignorant of the whole. The part can never be well unless the whole is well. And that is not only the physical side, but the emotional side as we think of ourselves as whole persons. So the challenge to psychosocial oncology, and there's been significant challenge, but we've made a lot of progress of late, is that it's primarily biomedically focused. Everyone is a super specialist in our own way, and patient care is very siloed. What I mean by that is that we create these super specialists in medical oncology, in radiation oncology, in surgery. We have breast cancer surgeons, we have surgeons that only treat lung cancer, GI cancers, and so on. So increasingly, there's a competition for funding, and I know we had dinner last night with a couple of colleagues of Dr. Grassi that talk about the limited funding available for the psychosocial aspect of patient care. In some ways, because it's a new discipline within the field of oncology, it's seen very much as an add-on and very difficult to debate the issue of why whole patient care is so important. I did a study in Canada a number of years ago, and I found that less than 3% of operating dollars in any cancer center is directed to the emotional side of the experience. And Rosangela, you can talk about that later, because I know in our conversation with you yesterday that you are the only one committed to and funded to do psychosocial oncology in your institution. And so the battle is still very much in front of us of how to take care of the emotional needs of the patient and family. So we've been trying to expand the culture of cancer care to be more inclusive of psychosocial oncology. We have conducted many research activities in terms of quality of life. There are a number of early studies that have taken place in Europe with the EORTC, the European Quality of Life Measure. We've done those in Canada as well. We've done a number of intervention studies trying to demonstrate by treating the whole patient, we're able to relieve the burden and improve their quality of life. We've talked about patient-staff ratios, as I've just discussed. Less than 3% of operating dollars is directed to the emotional care of the patient. We've done, as Dr. Grassi has done, a number of communication training studies. We've talked about the prevalence of distress, the number of patients that are diagnosed and the number of patients that are highly distressed. We talked about cost offset. What I mean by that is, can we reduce the financial cost in terms of healthcare provision by providing better medical care that embraces the psychosocial aspect of patient care. We've also been involved in standards and guidelines. I'll talk a little bit about that later. And there have been very strong advocacy movements in North America trying to continue to promote and develop the importance of psychosocial oncology. So the treatment today is now based on what we see the evolving language about precision medicine. And I would also advocate for precision psychosocial oncology through some of the work that we're doing in North America. The treatment is now based on diagnosis, on genetics, tumor receptivity, the best treatments targeted for the unique patient's biomedical profile, what their biology is like, what their genetic profile is looking like. And now we're seeing the evolution of whole patient care as being a criteria that is very much mandated and very much part of the standards of care in most institutions around the world. There's been a strong energy in the last 20 years to recognize that it's not just about the cancer, it's about the person. I should say that whole patient care is that key issue that we want to recognize in terms of how we treat patients. Many of you are medical students. I talked to a few of you earlier on, and you're here today to learn more about this aspect of care, but I do know that many of you will be involved in various aspects. I only urge you to begin to think about whole patient care as being part of your mandate as well. You may be able to treat the tumor, but it's also important to work with the person. And that's really why we're here today. So the goals of cancer care are really to cure the disease. Nobody will argue about that, and Ted Kennedy Jr. said that very clearly. It's to extend life as long as we can and to avoid premature death. But the new language today is about the relief of suffering, trying to normalize distress, destigmatize it so that it's not psychiatric in nature, but more about the patient experience and their willingness to talk and to share about their difficulties in facing cancer. And that's a distress that all patients will feel, irregardless of where they are in the cancer trajectory. The improvement of quality of life of patients, to reduce the burden of cancer, and there is a burden, as all of you can imagine. And when all that fails, we try to work with patients to provide them with an opportunity for a good death. Now, in North America and many places around the world, we're now talking about medical assistance in dying. I don't know whether that's an issue here, it is an issue here in Italy as well, or we also call it physician-assisted suicide. And that is one of the issues that we're struggling with in terms of how to really mitigate, how to control some of the adverse effects so that patients don't have to think about medical assistance as dying as their final decision, but really to focus on the quality of life and trying to enhance that as they go through their journey. So a number of years ago, Susan Sontag wrote a book called Illness as a Metaphor in 1978. And she said, despite advances and reasons to be hopeful, cancers create significant distress. And in many ways, it's synonymous with that fear of death, the fear of pain, and the suffering that they will experience, irrespective of the amount of advances that have taken place. I want to share with you a patient of mine a number of years ago who was a 57-year-old prostate patient. He was a well-established fellow in my city, and he talked about his cancer experience as he was nearing the end of his life. He said, cancer, it just keeps on pecking away from you. It's another way of saying taking away from you. I thought I was a strong person. Cancer comes at you from so many different angles. It just keeps taking away your energy. You lose your strength within yourself. It is really hard. There's no money. A lot of your money is dedicated to getting the help you need, buying some of the things that will give you some degree of pleasure. There's no money. You go to your line of credit. You begin to sell off stuff just to stay alive. So in 1999, the National Cancer Institute in North America said, we want to get away from psychiatric labels for patients. So we should be talking about the distress that patients experience across the continuum and not to pathologize it, because the distress they experience or the pathology as in a psychiatric nomenclature is really creating an additional barrier to patients living with the disease and how to get the support that they need. So the stress was defined as an emotional experience of a psychological, social, and spiritual nature, which extends across the continuum from time of diagnosis through the end of life, from normal feelings of vulnerability, sadness, fears, to disabling problems such as depression, anxiety, panic, social isolations, and spiritual crisis. And this is the term now that is widely embraced in all oncology, and I probably here as well. Not as much the psychiatric nomenclature that we would typically use in terms of use of the DSM, Diagnostic Statistical Manual. So I want to share with you a couple of, as we begin to talk about the science of psychosocial oncology and how we've evolved today, Homsey did a study where he asked patients the question, how are you doing today? Just like Ted Kennedy said, how are you doing? And the number of symptoms reported by that question was quite low. When they administered a standardized screening for distress tool, it was the number of concerns that patients voiced was 10 times higher than when asked, how are you doing? Let me go back. I want to be sure I got that. Okay. Leslie Fallowfield did a study as well. She asked 143 physicians about the psychological status of 2,300 outpatients in 34 cancer centers. It's a big study in a lot of cancer centers, and there's the reality that one response or one hospital doesn't influence the total outcome. Here we see that in her study of 2,300 patients with 143 physicians, 35% of the patients were misdiagnosed, misclassified. In other words, they received the wrong assessment based on the conversation they had with their patients. For us, it indicates a need that we need to do better than asking, how are you doing? Nurses, they're better able to recognize major distress, but have difficulty identifying distress generally using clinical judgment. So the tools are really critical here. Fred Ashbury, a colleague of mine in Toronto, did research looking at untreated distress and found that patients with untreated distress were 5 times more likely to use community health services. They're 2 times more likely to visit emergencies. They're likely to seek complementary and alternative medicines. And they push for 3rd and 4th line chemotherapy, even though the clinical judgment of the oncologist may not be in fact there. We did a couple of studies trying to integrate screening as a standard of care in Calgary in our hospital. We worked specifically with a high-risk cancer, the lung cancer group, and we administered the quality of life measure, EORTC measure, to all patients coming into the clinic for follow-up. What we found is that when greater attention was given to symptoms of distress when the reports were provided to the clinic, which is exactly what you would expect. The data is there, we have to do something about it. We did another study in 2004. This is a very interesting study. We had a donation of $15,000. We hired a number of nurses, and in a 1-month period of time, we we met with 3,100 patients coming through the cancer center. So all patients, it didn't make a difference whether they were new, follow-up patients or end-of-life patients. And overall, we found that 38% or 40% of patients met the criteria for general distress within the clinical range. So roughly 40% of patients are having a difficult time, irrespective of where they are in the cancer trajectory. So this is the nature of the problems. We found that fatigue and pain were the highest level of problems of our cancer patients, following the various emotions of depression and anxiety. And strangely enough, or not strangely as it is in Calgary, it's probably the same thing in here, very difficult to get parking spaces, so patients are always worried about how to get that kind of level of support by coming into the center. As well, appearance, coping, sexuality, and financial concerns are an issue. So what have we learned? What we've learned from the few studies that we've done is what we measure is what we act upon, and not relying only on clinical acumen, on what we see or hear from the patient when they respond to how you are doing. This is a paper that I did with Bob McMurtry, who was the Chief Medical Advisor in Canada back in 2005, and it really is the impetus to provide some direction of change. So I want to talk now about precision supportive care, the future directions based on the science of what we're doing. So as you all know, as physicians, about to be physicians, you measure objectively the vital signs of body temperature, pulse, heart rate, blood pressure, and respiratory rate. I'm sure you all know that. I'm not giving you anything new. But what you probably don't know is that pain, as a subjective measure, was earmarked as the fifth vital sign back in 1999. And also, given the level of distress, 35 to 45% of significant level of multifactorial distress across the cancer care is highly visible. We advocated for distress to be recognized as the sixth vital sign. We said that distress is highly prevalent, it needs to be monitored and addressed. It's more than anxiety, and I really want to stress that. It's not just about anxiety and depression, it's about the pain, and we saw that in some of the studies, the fatigue, the other nutritional problems, weight loss, and so on. And it needs to be considered as a point of entry, the time they come into the cancer center, and should be followed by appropriate responses, not just doing the screening, but doing something about the screening, referring to the right professional at the right time. How am I doing for time, Luigi? Good? Okay, thank you. He warned me that he would cut me off exactly at 45 minutes. So I think that is really critical here. We need to not only screen, we need to do something about the screening. So in 2004, as the lead in psychosocial oncology for the Canadian Strategy for Cancer Control, I advocated for the endorsement of distress, emotional distress, and now I would just say distress alone, to be seen as the sixth vital sign. And the council, the Canadian Strategy Council, agreed that we need to move beyond just the physical and pathologizing the psychological issues, but including it as a necessary measure from time to time repeatedly. And as a vital sign, we do repeat measures of our basic biological signs, but we should also do screening about the psychological as well. So then following the endorsement by the Canadian Strategy of Cancer Control, my colleague Linda Carlson and I wrote an article for the Journal of Clinical Oncology, and we see that they published our correspondence advocating for why distress should be seen as the sixth vital sign. We then went on to publish a number of papers in psycho-oncology talking about future directions in cancer care, now the inclusion of the emotional aspects of the patient experience. And then I wrote a paper with Jimmy Holland, who's often considered the mother of psycho-oncology in the United States, where we advocated for the guidelines for distress management and case for making distress, again, so there's been a lot of momentum around distress being the sixth vital sign and why it should be included as a standard of care. Accreditation Canada embraced us, which is really an important step because up until now, it was the literature, the science, and now it becomes an automatic demand of cancer centers to screen patients for distress and to follow up with ongoing support and care. And I think this is one of the first programs globally that really embraced distress as a sixth vital sign and the requirement of measure as an accreditation guideline in Canada. Then psycho-oncology asked us to do a monograph in psycho-oncology related to the importance of distress, and we had I thought about 600 papers submitted. People want to really do the right thing in terms of embracing the importance of screening as a standard of practice. Then UICC said effective pain management and control and distress management should be a part of services universally available to all patients. And in fact, we've done a considerable amount of work with UICC in terms of working out with some of the African nations on teaching them about psycho-oncology and about stress management as well. IPOS in 2010 in Spain said quality cancer care must integrate psychosocial oncology into routine care. Psychological care should be recognized as a universal human right, and distress should be measured as a sixth vital sign after temperature, blood pressure, pulse, respiratory rates, and pain. Lucia Travado and a couple of others from the European Cancer Policies also advocated for distress management. And you could see there's a beginning of a global movement towards the importance of embracing distress and including it now beyond just the biomedical side of what we do. And of course, Luigi Grassi did a multi-center nationwide study here in Italy, talking about the importance of screening for distress as well. And this is an example of the tool that they use, the distress thermometer on the left and the problem checklist on the right. So kudos to you, Luigi, for making that happen here in Italy. I know that screening is now part of the standard of practice as well. So the American College, everybody is beginning to see the movement, the energy behind moving away from the silo of just biomedical care, but now the inclusion of whole patient care. I want to quote Eduardo Casap, who is president of UICC in Shenzhen, China. He said, "We expect that recognizing distress as the sixth vital sign will improve the treatment of cancer patients, improve the outcome for cancer patients, and improve the effectiveness of cancer care systems around the world." So really, in just a short period of time, we're seeing that what was simply an add-on is becoming embraced as an important component of whole patient cancer care. So let's talk about extending the reach. How are we going to do that? Because there's still very little money. There's still very little commitment. There's a lot of theoretical commitment, and we need to show that we're making a difference. So I want to talk about Jennifer Temmel's study. Probably all of you know about her work with non-small cell lung cancer. And she said screening for distress, early symptom management adds to better quality of life, less depressive symptoms, and a longer survival rate. So here we're beginning to see not only the benefit to the patient in terms of quality of life, but also the extension of life. And that is what we're all here about, is how to improve the lifespan of our patients struggling with disease as well as the quality of their life. One of the most important studies is a study done by Ethan Bash. I'm sure all of you have read this paper. If not, I'll just enlighten you and you could follow up on your own. But he talked about screening and symptom management and monitoring and treatment patients. And he did a large randomized trial doing that. It was a controlled study. So what did Ethan Bash find in 2017, reported at ASCO? That cancer patients are more responsive to care in real time, It prompted early action before complications got worse. It improved the symptoms for control, symptom management. It enabled patients to function physically and maintain mobility better. And if patients feel better, they live longer and use fewer resources. So that's the outcome. And it's so important to recognize that a prompt response to distress, multifactorial distress, really has some benefits that are quite significant. Here are the survival advantages. Take a look at the yellow versus the dark line. You could see it better than I could, and I don't want to point to my computer. but you can see the yellow line, in fact, enhances quality of life and extends life longer than the usual care without psychosocial attention. Harold Burstein, who works at Dana-Farber and as an ASCO commentator, wrote on this particular paper, this is an exciting and compelling study showing that patient-focused teams can improve ER visits, just like Fred Ashbury, improve quality of life, and improve overall survival. And he went on to say, which is critically important, if this were a drug, chemotherapy, that had a survival advantage of this magnitude, this size, it would be priced at $100,000 in the United States. And we would all ask, how can we get access to this chemotherapy, to this drug, to improve the patient care and extend life? So I'm about to conclude. I want you to remember that it's critically important to embrace what I consider the science of caring. Implement into all your programs routine, I don't mean just one time, but routine screening for distress as a sixth vital sign using standardized measures. There are a number of measures that are available out there. At another time, I'll go through some of the stuff that we're doing in Canada. And I want you to not only screen, but manage the distress and symptoms in a very timely way. So in conclusion, it's about the metrics, it's about the numbers. It speaks to the science of caring. It destigmatizes, it takes away the mental health issues of being anxious or depressed. It improves patient-physician communication because if you could target your conversation around the symptoms, you can improve that relationship. It saves time and it reduces cost.
Thank you, Professor Bultz, for your stimulating, inspiring, moving key lecture. Thank you very much for the deep of our hearts. To you, Frank, and all the patients that are behind you. Grazie del suo intervento davvero stimolante, interessante, perfino commovente. I think it's better to stick to the time schedule for the discussion because at 12 o'clock we have a discussant here. Rimandiamo tutte le domande che sarebbero tantissime alla discussione che avverrà dopo mezzogiorno.